the PTA Annual Convention. We are live and we are doing this virtually. And we are sharing this particular conference with our friends from MedSynapse. And they're broadcasting us all throughout the world. We do have some delegates listening to us as far as Europe, South Africa, the rest of Asia, and of course, the Philippines, all throughout our country. So it's a pleasure for me to welcome all of you to the second day of the PTA Annual Convention. I'm Dr. Jeremy Robles. I'm the scientific chair of this year's PTA Annual Convention. On Monday, we had our first run with our first three lectures, very interesting lectures and very interactive audience. I'm sure all of you learned a lot from those three lectures. And some of the questions that were not answered during those sessions will be answered today. Today, we will talk about extremes in a spectrum of diseases related to thyroid physiology as well as pathology, and then at the same time, how this correlates whenever you have COVID-19 infection. Our first lecture for today will be done by Dr. Nemencio Nicodemos. He is the current president of the Philippine Thyroid Association. The moderator will be Dr. Alta Gracia Damalerio. She will be joining us from Cebu, while Dr. Nicodemos will be in Manila. The second lecture for today will be done by Dr. Eric Mendoza. He will be our speaker. He will be speaking in Manila, and he will be moderated by the moderator, Dr. Orabel Libutan, who will be in Bacolod City in Central Philippines. The last lecture today will be done by myself. I will be your third lecturer. I'm going to talk about managing thyroid disease in pregnancy in the COVID-19 pandemic. My moderator for this session will be joining us from Southern Philippines, and that's Iligan City, Dr. Raquel Bruno. On day 3, this Friday, again, we're extending our invitation for you to join us for the last 3 lectures for this year's PTA Annual Convention. The lecturers will be, for the first session at 4 p.m. on Friday, we have a panel discussion on thyroid malignancy in the time of COVID-19. Our guest speakers, Dr. Shoberg Ko and Dr. Wenceslao Lauderes, will be joined by their moderator, Dr. Silvernon Israel, who is from Bohol. The next lecture for robotic surgery in thyroid disease in the time of COVID-19 will be done by Dr. Jeffrey Geronimo Domino, who will be moderated by Dr. Domingo Sampang. Lastly, the final lecture for this year will be done by Dr. Nestor Eric Leplano, and he will emphasize and give us a lot of tips on telemedicine and teleconsult strategies for thyroid patients during the COVID pandemic. The session will be moderated by Dr. Arisa Soria, who will be joining us from Zamboanga City. And that's it for day 3, and that's the final day. For today, we will continue on with our lecture series for our contingencies and strategies for thyroid disease management in the time of the pandemic. So for this afternoon, we have 3 lectures. I just wanted to show to you the officers and board of trustees of the Philippine Thyroid Association. The president is Dr. Nemencio Nicodemos, the vice president, Eric B. Cruz, secretary, Dr. Arnel Pauco, myself as the treasurer, and of course, we have our PRO, Dr. Jeffrey Geronimo Domino, who will also be lecturing in one of the lectures on Friday. Joining us here are the board of trustees, Dr. Francis Estrada, Dr. Ida Lim, Dr. Eric Mendoza, who will be lecturing with me today, and Dr. Wenceslao Lauderes as our immediate past president. So let's begin with day 2 of our PTA Annual Convention. Dr. Alta Gracia Damalerio, are you ready to take over? Thank you so much.
Thank you for that, Dr. Robles. Again, good afternoon, everyone. I am Dr. Alta Gracia Damalerio, and I will be your moderator for the first session. Our first speaker is an internist and an endocrinologist. He obtained his medical degree at the University of the Philippines College of Medicine. He had his residency training in internal medicine and fellowship training in adult endocrinology in Philippine General Hospital. He had his post-fellowship training at the Mayo Clinic in Minnesota, USA. He is a professor at the University of the Philippines College of Medicine, Department of Biochemistry and Molecular Biology, where he was awarded as Most Outstanding Medical Teacher in the Basic Sciences. He is also a clinical professor of the Department of Medicine at the Philippine General Hospital, where he's recognized by the UP Medical Alumni Society in America as Best Teacher. He is a past president of the Philippine Society of Endocrinology, Diabetes and Metabolism, a regent of the Philippine College of Physicians, the vice president of the Philippine Association for the Study of Overweight and Obesity, and he is the current president of the Philippine Thyroid Association. Doctors, let us all welcome Dr. Nemencio Dicodemos Jr.
Thank you very much for the kind introduction, Dr. Altagracia de Malerio. I would like to thank everyone who's now attending this virtual convention of the Philippine Thyroid Association. And we hope that in these sessions that you will hear this afternoon, you will learn a lot and bring home a lot of valuable lessons in your practice. I will now be sharing my screen. The topic that was assigned to me by our scientific chair, Dr. Robles, is managing hyperthyroidism during the time of COVID-19 pandemic. It is indeed true that we are still in the time of the COVID-19 pandemic, whereas a lot of the countries in other parts of the world have received perhaps their vaccinations. Here in the Philippines, we still have to receive our vaccinations. Perhaps the earliest will be next week. And so it is still very much proper and timely that we talk about how to manage patients with hyperthyroidism during this time that we are still in the pandemic. Let us go back a few months or even perhaps say a year or so before this time and try to look back at how we used to manage our patients with hyperthyroidism. This is how we would usually go through our patients. Once we have diagnosed them with hyperthyroidism, we will discuss the advantages and disadvantages of the different kinds of treatments. And the treatments that we give to our patients with hyperthyroidism can either be treatments to control the hyperthyroidism or definitive treatments. And so, under the control of hyperthyroidism, we use antithyroid drugs. We know that part of the initial regimen is to consider the antithyroid drugs which will render the patient's hyperthyroidism controlled or in a euthyroid state. The recommendation is usually among patients who have good risks for eventual remission is to give them antithyroid drugs for about 12 to 18 months. That is if they are likely to achieve remission. And for those patients who have toxic single or multiple nodules. In these patients, they might require lifelong treatment with antithyroid drugs. Subsequently, we may now discuss with the patients the definitive treatment, particularly for those patients where perhaps the risk or the chances of developing or going into remission is very low. Perhaps we should discuss with them the definitive treatments. And these include radioactive iodine, which we offer for patients with Graves' disease or toxic multiple nodules, or even for the toxic single nodules. These can be given, of course, as an alternative to surgery unless the patient is pregnant. It is important that these are first-line definitive treatments that we offer to our patients after we have controlled their hyperthyroidism with antithyroid drugs. Another form of definitive treatment that we offer our patients prior to the pandemic is surgery in the form of thyroidectomy. And of course, we offer surgery for our patients with Graves' disease if compression or malignancy is suspected or if other treatments are unsuitable. This particular form of management is also important for toxic multinodular goiters or even for single nodules if radioactive iodine is unsuitable. And so that was how we managed our patients with hyperthyroidism prior to the pandemic. It seems that this algorithm is something that is already very much ingrained into the way we manage our patients. But then COVID happened. Here in the Philippines, we all remember that a year ago, the first case of the novel coronavirus infection in the Philippines was reported, and as we know it, everything changed thereafter. A few weeks after the first case was reported, Manila was already placed into enhanced community quarantine, short of saying that we are in a lockdown. But it is similar to a lockdown because by then, a lot of things change, particularly the way we do our consultation with our patients and the movement of patients. In fact, these are the things that happened as a result of the COVID-19 pandemic. Number one, people's movements were restricted. Because of the enhanced community quarantine, people were not allowed to go outside except if for necessary reasons or conditions. Senior citizens, those above 60 years old, were not allowed to go out, and children were not allowed to go outside. Several tertiary hospitals were converted into COVID-19 referral centers. And we all know that our tertiary hospitals serve as the clinics or even the centers where our patients go to meet their endocrinologist in order to have their thyroid disorders controlled. 3, outpatient clinics were closed. This is particularly true for government hospitals where a lot of our patients also go to seek consultation and to see their endocrinologists. And patients were afraid to see their doctors face to face and also vice versa. We all know that, of course, because of the uncertain nature of the virus at that time, everyone was afraid that they might get the virus whenever they go out, and therefore there was extreme caution that was practiced by everyone in order to ensure that they are safe and they will not get the COVID-19 virus. And so, because of all of these things that happened, definitely the impact on health-seeking behavior and even the consultation of our patients with thyroid disorders was greatly affected. And finally, to make matters worse, even if patients wanted to go to their doctors and even if doctors can see their patients, a lot of diagnostic centers were not fully operational. And therefore, patients cannot have their blood test drawn for testing of thyroid function or even other diagnostic tests that will be necessary in order to complete their consultation with their physicians. All of these happened as a result of the pandemic. And so, because of that, we had to do things differently. And of course, as physicians, we know that majority or if not all of our steps must be evidence-based. The problem with the COVID-19 crisis is that it happened so fast that perhaps there was not even any time for us to do any studies on how to manage our patients with hyperthyroidism during such pandemic. But interestingly, in December of last year, in the middle of the pandemic, this particular article was published by Dr. George Cahaley in the Journal of Clinical Endocrinology and Metabolism, or the JCEM. It outlined to us the management of Graves' disease. And what Dr. Cahaley recommends is that, of course, in a patient where Graves' disease has already been confirmed by low TSH, it is important that we ask for the testing of the free T4 and the T3. And of course, an elevated FT4 or T3 with low TSH will confirm overt hyperthyroidism. Another test that is recommended by Dr. Cahaley in this article is thyroid ultrasound. By doing so, we will be able to determine if there is a nodule or multiple nodules that are present in the thyroid gland. And finally, another test is recommended to complete the diagnostic algorithm for hyperthyroidism or Graves' disease. and that is the presence of your TSH receptor antibodies. And of course, we know that a positive TSH receptor antibody would make now the diagnosis of Graves' hyperthyroidism. What makes this algorithm a little different from what we know prior to the pandemic is that it introduces to us two other important diagnostic tests that we must order to complete our diagnostic algorithm. Aside from getting the thyroid function test, your low TSH and elevated T43, the thyroid ultrasound, and very importantly, the TSH receptor antibodies should now be part of the initial tests that we should be ordering for our patients in order for us to come up with the definitive diagnosis. After we have diagnosed Graves' disease, comes management. And the management that is recommended by Dr. Cahaley in his article is the use of methimazole. And recommendation is to put these patients on methimazole for 18 months in adults or at most 36 months in children, making sure that serious adverse events are monitored and that compliance of the patients are also monitored. Of course, afterwards, we will discuss with the patient the definitive treatment. And they are still in the form of either a radioactive iodine treatment or total thyroidectomy. So similar to the pre-COVID pandemic era, our interventions consisted of controlling the hyperthyroidism and advising definitive treatment. Dr. Cahaley in this article gave the different mechanisms, advantages, and disadvantages, including major adverse events of the three types of interventions that can be given to patients with Graves' disease. And of note is that there are certain things here that are impacted by the COVID-19 pandemic. For the antithyroid drugs, despite the fact that they are very effective in inhibiting thyroid hormone synthesis, we know that the disadvantage of your antithyroid drug include a high relapse rate, frequent monitoring, adverse events, which may be rare, and compliance. What is now important during the COVID-19 era is that if you are giving your patient antithyroid drugs, you are supposed to ask them to come back to you with a repeat of their thyroid function test as part of the frequent monitoring to adjust the dose of your antithyroid drugs. This, therefore, will be affected by the changes that happened during the pandemic. How about compliance? Of course, we also know that during the time of the pandemic, because some of our patients are not able to see their physicians, some of them may even stop the medications without the advice of their physicians. And so it becomes a problem as well. How about radioactive iodine treatment? This is a definitive treatment which we know has high efficacy and has no risk for surgery or anesthesia. But what we also know is that it has its own set of disadvantages. And what is pertinent during the COVID-19 pandemic era is the radiation exposure. Why? Because after a patient is given radioactive iodine, he is advised to self-quarantine, similar to the quarantine that our patients with COVID-19 do. But this is, of course, in order to protect the other members of the household. And the number of days where the patient also has to quarantine himself or at least separate himself from the other members of the household is around almost a week, similar to what we also do to patients with COVID-19. And thus, this also becomes another issue for patients because during this time of COVID-19 pandemic, of course, the mental health of our patients are affected when they are in isolation. Another important adverse event that is also impacted by COVID-19 pandemic is the fact that patients who take in radioactive iodine treatment may develop short-term sialadenitis or even thyroiditis. And as such, they will need to visit their physicians perhaps more often when they do develop these adverse events. And so if they cannot go to their physicians because of the isolation and the quarantine, then this also becomes a problem. Finally, we know that total thyroidectomy is another definitive treatment with highest efficacy under the hands of experienced surgeons, and it will give rapid control of hyperthyroidism. Problem that is related to the COVID-19 pandemic is the need for hospitalization. Of course, during the time that a lot of hospitals were made into COVID referral centers and that there are a lot of COVID admissions in the hospitals, the non-COVID admissions suffered. And thus, patients who were scheduled for surgery, if they were elective surgery, had to be postponed and they had to wait for a time when it was already safer for them to be admitted to the hospital. And so this also became an issue during this COVID-19 era. Given all this now, is there really evidence that we can hold on to that really came out during the past year that will guide us as clinicians on the management of hyperthyroidism in the era of COVID-19? A quick search of the PubMed I did this morning revealed that when you search hyperthyroidism and COVID-19, there were no clinical trials, there were no randomized controlled trials, but there were 7 reviews with 1 clinical practice guidance. And so given the limited literature that we have, the recommendations that I will give you in the next couple of slides come from the reviews and expert opinion that were published in the PubMed. One thing that is good perhaps among patients with hyperthyroidism is that there is no evidence that those with uncontrolled thyroid disease are more likely to contract viral infections. And therefore, our patients with hyperthyroidism have the similar risk as any other person beside them of developing COVID-19. That's good, right? But what is not good is that there was a meta-analysis that was performed looking at the association of the development of severe COVID-19 infection with that of thyroid disease. And in this meta-analysis of 8 observational studies with a total of more than 2,100 patients with COVID-19, they were able to show that thyroid disease is associated with the severe COVID-19 infection. And in fact, having thyroid disease increases the risk of severe COVID-19 more than 2-fold. And so even if our patients with hyperthyroidism are not at higher risk of developing COVID-19, when they do develop it, they are at higher risk of developing the severe type of COVID-19. Therefore, how should patients with thyroid dysfunction be managed in a crisis setting, just like what we are experiencing right now, particularly with limited resources? And this is very applicable to us here in the Philippines and perhaps even in our neighboring countries where perhaps resources are limited. First is the issue of diagnosing the condition. How do we diagnose hyperthyroidism during the COVID-19 pandemic? It should continue to be based on clinical suspicion and supported by characteristic biochemistry results. We should still check the TSH receptor antibodies as recommended by Dr. Cahaley in his paper in order for us to identify the underlying diagnosis, particularly Graves' disease. And thyroid ultrasound, although it is recommended by Dr. Cahaley, may have a limited role, particularly in the COVID-19 pandemic, because as we said, a lot of the diagnostic centers are not fully operational during this time, and that includes thyroid sonography. The caveat, however, in making the diagnosis is that the determination of malignancy risk associated with palpable thyroid nodules can usually be postponed unless there are particular characteristics that indicate a high-risk thyroid cancer. And so at this time, really, our focus is to control the hyperthyroidism, and that ruling out the malignancy may usually be postponed because we know that prognosis-wise, when you talk about differentiated thyroid cancers, they tend to be indolent. However, it also depends if the patient has high risk for thyroid cancer. And what are these clinical features that will increase, that are associated with higher risk of thyroid cancer? To share with you a systematic review and meta-analysis of 41 studies of more than 29,000 patients, they were able to determine that these clinical features are associated with an increased risk of thyroid cancer. A family history of thyroid carcinoma, a thyroid nodule with more than 4 centimeters or at least 4 centimeters in size, singularity of nodule, a history of head and neck irradiation, and even the male gender. These are clinical features associated with an increased risk of thyroid cancer. If, however, the patient was able to have a thyroid sonography done, we know that the American Thyroid Association has given us these sets of findings that are associated with high risk of malignancy, which includes microcalcification, a hypoechoic nodule with irregular margins, taller than wide, and of course, those with extrathyroidal extension, and also nodules with irregular borders and suspicious lateral lymph nodes. If these are present in the ultrasound of the patient, then perhaps we can be more aggressive in managing this patient even during the time of COVID-19 pandemic. What is now the impact of COVID-19 on the treatment of hyperthyroidism? At this time, the recommendation is, unless there is an emergency, and emergency is defined as either hyperthyroidism refractory to antithyroid drugs, very large goiters with severe compressive symptoms, unless there are these factors, definitive treatments should be postponed. And so really our goal as clinicians during this time is to just make sure that the hyperthyroidism is controlled biochemically, and that definitive treatment may be advised once conditions are a lot better. Of course, unless there is an emergency situation. Now, what is the recommended regimen for treatment of thyrotoxicosis? I have reviewed with you at the start of my talk the recommendations and even the way we managed hyperthyroidism prior to the pandemic, and even in the article that was published by Dr. Cahaley at the height of the pandemic. But here, what is important is that after the initial control of thyroid hyperfunction with the appropriate dose of your antithyroid drug, you have to titrate your antithyroid drug using the lowest dose of the drug that maintains euthyroidism. But look here, there is another recommendation. There is that option to start the patient on the block and replace regimen. Patients whose hyperthyroidism, however, is well controlled with a titration may continue their treatment without changes. But if they are on a prior block and replace regimen and they are controlled on that, they should still continue with the block and replace regimen. And the resumption of the thyroid function testing should be undertaken as soon as is practicable. So you can see here that there is this new recommendation that aside from the usual antithyroid drug titration regimen, the concept of block and replace has resurfaced. And therefore, it is important that we assess thyroid status in if the patient has new or worsening features of thyroid eye disease. Let us take a moment to review the case for block and replace regimen during the time of pandemic. We know that over the coming weeks or months, since it may be difficult to undertake biochemical monitoring due to the closure of certain diagnostic centers, due to the fear of patients to go out and have their blood tested, or even due to the fear of the patients to consult their doctors, block and replace regimen should be considered as initial treatment. And this is the recommendation that was published in the European Journal of Endocrinology. The block and replace regimen is recommended as an initial treatment, especially in patients presenting with new or relapsed hyperthyroidism. Studies have shown that they have similar efficacy and long-term cure rates as titration regimens compared to the titration of the antithyroid drugs. And if the patient develops significant symptoms while being treated, according to the algorithm, thyroid function test should be tested and the patient should discuss with the endocrinologist the advice on further treatment. Now, just to give you now the advantage of the block and replace regimen and why it was recommended in the European Journal of Endocrinology, because it avoids repeated thyroid function testing and visits to the physician during the pandemic. And I think that was one of the main considerations why the block and replace regimen really was part of the recommendation. But the drawback of the block and replace regimen is that there is an increased risk of adverse events due to the use of the higher doses of antithyroid drugs. In fact, this is how the block and replace regimen is recommended for adults. See here that depending on the baseline free T4 of the patient, the drug carbimazole may be started or methimazole may be started. And for patients with very much elevated baseline free T4s, the dose of methimazole that should be started is around 30 milligrams or equivalent to 40 milligrams of carbimazole. And after 4 weeks, they can continue the same dose of the methimazole, the high dose of methimazole, 30 milligrams once a day, but levothyroxine will be added at a dose of 75 micrograms per day if the body weight is less than 55 kilos, or 100 micrograms per day if the body weight is greater than 55 kilograms. So you can see here that you're actually combining a blocking agent, your methimazole, with the replacement of your levothyroxine. That's why it's called block and replace regimen. And after 6 months, the patients are asked to come back for reassessment by the endocrinologist. See here that that duration is actually very long. And again, that is intended to reduce the number of visits and also to reduce the number of laboratory tests that the patient needs to do during the COVID-19 pandemic. Just to look at the evidence, one such evidence was published last year looking at, and this is a multi-center phase 3 open-labeled randomized trial comparing now the block and replace with the dose titration of antithyroid drugs among young patients, 2 to 17 years old, with newly diagnosed thyrotoxicosis in 15 centers in the UK. 82 patients were randomized to either the block and replace or the dose titration of the antithyroid drugs, and they were treated for 3 years. The primary outcome was the percentage of serum TSH levels in the reference range between 6 months and 3 years, while the secondary outcomes included the proportion of free T4 levels in the reference range, including adverse event frequency and 4-year outcome. And this is what was the result. See here that comparing the block and replace regimen with the dose titration of the antithyroid drugs, TSH-wise, the percent of those within the range is almost similar. And when it comes to the free T4 levels, the percent of the time that they had free T4 within range, block and replace, and dose titration also gave you almost similar results, thus telling us that there is no evidence to suggest that the block and replace regimen is superior when compared to dose titration of antithyroid drugs. When it comes to adverse events, however, you can see here that there were more adverse events that are related to the treatment in the block and replace, and that there were serious adverse events such as neutropenia that were seen, although very low frequency, 3 patients in the block and replace and 1 patient in the antithyroid drug dose titration regimen. Another issue is because of this now, the neutropenia, a granulocytosis is a possibility that may happen during the treatment. And how do you differentiate now between an infection caused by COVID-19 or even a granulocytosis caused by the antithyroid regimen or even by an infection? Since the symptoms of neutropenia may overlap with the symptoms of COVID-19, such as fever, new continuous cough, and flu-like illnesses, it becomes a challenge. It is difficult, if not impossible, for patients and physicians to distinguish between these two diagnoses clinically. And it is plausible that this rare adverse effect of antithyroid drugs favors now the progression of COVID-19, possibly through a reduction in the innate immune response or through generalized immune suppression. So how do we manage a granulocytosis in people on antithyroid drug during COVID-19 pandemic? The European Journal of Endocrinology recommends considering the discontinuation of the antithyroid drug in patients with such symptoms suggestive of neutropenia, and that an urgent, full, complete blood count must be done to measure neutrophil count. And depending on the manifestations and history, testing for COVID-19 should also be considered, since we cannot rule out that this neutropenia may be due to COVID-19 as well. How do we manage neutropenia in a resource-limited setting? It may not always be possible to check a full blood count at the onset of symptoms, and therefore the suggestion is that once the patients have symptoms, they should stop their antithyroid drug and restart only after a week if they become asymptomatic. A reduction in the dose of the antithyroid drugs or the use of an alternative drug may be considered, and if symptoms worsen during the period that they are off antithyroid drugs, or that there is recurrence after recommencing the drug, the patient should seek urgent medical attention. I'm sure you will agree with me that this particular situation of neutropenia is something that we do not want our patients to develop, particularly during this time of pandemic. But who are the patients who are at particular risk of COVID-19 infection, and therefore we must be more worried about these patients? They are the patients with thyroid eye disease on immunosuppressive medications, basically that is due to the immunosuppression that they have, and pregnant women with hypo or hyperthyroidism, which will be discussed by our third speaker today. How do we manage Graves' orbitopathy in the time of COVID-19? It depends on the severity. Mild Graves' orbitopathy does not require active treatment with immunosuppressive drugs, and you may just advise the usual preventive or therapeutic actions. We may also give selenium if indicated. For those with moderate active Graves' ophthalmopathy, systemic treatment should be postponed, but local treatments and preventive measures must be advised. And we should shift the IV steroids to oral glucocorticoids at home to avoid unnecessary visits to the hospital. But for those with severe active Graves' ophthalmopathy, you should give aggressive intravenous glucocorticoid treatment to avoid irreversible loss of vision and that orbital decompression should be deferred unless there is an immediate threat for the patient's sight, and rehabilitative surgery should also be postponed. This is the randomized controlled trial where they used selenium for patients with Graves' orbitopathy, and they gave sodium selenite at a dose of 100 microgram twice a day for 6 months, and then they were followed up for another 6 months. What it showed was that when it comes to Graves' orbitopathy, there was a significant improvement compared to placebo. And you can see here that this was significant both at 6 months and also at 12 months. And that was 6 months after they have withdrawn treatment. So what is the general advice for patients with thyroid disease during COVID-19? You must reduce the risk of progression of orbitopathy by discontinuation of cigarette smoking and selenium supplementation if indicated. And that you must avoid teardrop leakage, and careful adherence to personal protective equipment must be adhered to during this time. But what if the patient already has COVID-19 and is already suffering from this infection while at the same time having Graves' hyperthyroidism? How do we treat them? Any hyperthyroid patient with COVID-19 infection should continue their antithyroid drug because uncontrolled hyperthyroidism adds on COVID-19 infection to determine an unfavorable outcome. And as we said, they may develop severe COVID-19. Methimazole and PTU are administered orally if COVID-19 patients cannot eat, or by nasogastric tube if he or she is unable to swallow. And in extreme situations, alternative routes can be used such as suppositories or water enema formulations. In summary, my dear colleagues, what have I shared with you? And hopefully you can bring this home while in order for us to manage our patients with hyperthyroidism during this COVID-19 pandemic. 1, uncontrolled thyrotoxicosis may be associated with more severe complications from COVID-19. 2, symptoms of infection from COVID-19 are indistinguishable from those of antithyroid drug-induced neutropenia, and that the withdrawal of antithyroid drugs and urgent neutrophil measurement is advised. Block and replace regimens are preferred for newly diagnosed hyperthyroidism in adults and children, although the evidence say that they have the same efficacy even with the dose titration of your antithyroid drugs. And conjunctival involvement of COVID-19 may make the diagnosis of thyroid eye disease difficult and may present a particular risk of infection. Thank you very much.
Thank you for that very informative and very well explained lecture, Doc. Okay, so we've learned that thyroid does not increase the risk for COVID-19 infection. However, when they develop it, they are at higher risk for developing severe COVID-19. And since it may be difficult to do biochemical monitoring for thyrotoxicosis, block and replace regimen is recommended as initial treatment. However, may have a disadvantage of higher risk for adverse effects of the ATD. Okay, so we have a few questions here. First is low vitamin D association with thyroid dysfunction. Is it a myth or a...
Okay, actually when it comes to vitamin D, there is not really a clear association as of yet when it comes to the development of hyperthyroidism or even association with the control of the hyperthyroidism. So at the moment, we're still not considering a high degree of association between vitamin D status and the hyperthyroidism.
Okay, thank you for that, Doc. Next is patients with mildly elevated free T4 with no symptoms, signs or symptoms. Do we need to treat it or not?
Okay. Of course, during this time of the pandemic, it is important that whenever they have hyperthyroidism, even if they are asymptomatic, that we should give them treatment in order to not worsen the prognosis or the course of the disease. But we might just need to give lower doses of our antithyroid drugs for these patients.
Okay. And then we also have a question regarding the selenium. The usual selenium we have is combined with vitamin E and is just around 25 micrograms per tab. How do you give the 200 micrograms per day of selenium in your patients with GO?
Well, actually, that was also my initial concern, because when we look at the available doses in our drugstores, the usual drugstores, it's just really the low dose. But what we do have these higher doses in some of the supermarkets, the commercial supermarkets that we have. They actually are able to sell selenium doses that are of 100 microgram doses.
Okay. So we'll just double it, or 2 tabs. And then regarding vaccination, so COVID-19 vaccine with thyrotoxicosis, is it highly recommended or must be careful to have the vaccine?
Oh, that is a very interesting question. Unfortunately, I don't think I have the evidence to support my recommendation. But of course, if the patient's hyperthyroidism is adequately controlled, and as long as they do not have any comorbid conditions that will prevent them from getting the vaccination, then I would still recommend vaccination among these patients.
Okay, so it should be controlled. Next, Doc, did you encounter data where it reports COVID-19 induced thyroid storm?
Oh, okay. There wasn't any data, any literature at all, but there was a publication on recurrent hyperthyroidism due to COVID-19, but not really the ones that will lead to thyroid storm.
All right, so let's see. Okay, can you give antithyroid drugs on an every other day basis if patient requires only low dose, since it's already high?
Right.
Yes.
Of course, we have to understand the half-life of our antithyroid drugs. And if we are using our methimazole, we know that our methimazole has a half-life of around 4 hours. And thus, if you give it every other day, the second day, the patient doesn't already have enough serum levels of the medication. So that will be difficult if you want to control the hyperthyroidism. What I would suggest, however, might be to cut the tablet in half if they really want to give lower doses of the drug to the patients.
Okay, Doc. So next is, we have another question regarding how do we explain the risk with the reintroduction of ATD in patients who develop a granulocytosis, since it should be stopped for a week?
Yeah, exactly. I think it is something that we must be honest with our patients, that it is important for us, even when we start them on antithyroid drug, that there is that small possibility that they may develop a granulocytosis. It is very small, in fact. But again, we must tell them that if these do develop, they must at once seek consultation. And of course, the definitive treatment should be given once they do develop a granulocytosis. But during this time of COVID-19 pandemic, if they are not able to have definitive treatment like radioactive iodine therapy, then we can advise them to take the antithyroid drug, but this time giving them lower doses, particularly with methimazole, since we know that granulocytosis with methimazole tends to be dose dependent as well.
Okay, Doc. So another question regarding ATD-induced granulocytosis. Can you comment regarding hyperthyroidism for patients who had ATD-induced granulocytosis, and how long could it be given?
Okay. Lithium, as we know, is something that is also given as an option for those patients who already had a granulocytosis secondary to the usual drug, methimazole and even PTU. This can be given so long as eventually we will need to, of course, give the definitive treatment for our patients, because lithium has its own set of side effects as well.
All right. So yeah, I guess we don't have any other question. The other question can be answered to the next session. Thank you so much, Doc. That ends our first session for today. Now I will turn you over to Dr. Jeremy Robles.
Thank you,
Thank you,
Alta.
Madam
Good
Valerio.
job. Congratulations. Nemi, as always, very good lecture. I think if you notice, some of the questions actually came in from MedSynapse. And we are being viewed all throughout Asia as well as areas outside of Asia. As I mentioned, we do have some viewers from the Middle East, Europe, as well as far as Australia as well. No? So if you have any questions, please do send them. We are getting your questions. What we're going to do is that we're going to ask all the other panelists to join us for one last session for a panel discussion after all the 3 lectures have been completed. So you can still send your questions. We'll just take note of them and try to answer the questions later on. So we'll move on to our next lecture for this afternoon. If we talked about hyperthyroidism, then pretty sure the other end of the spectrum is hypothyroidism. We have another interesting lecture. Of course, we have one of the very good speakers from the Philippines as well. Let me share the introductory slide. So joining us for the next session is Dr. Eric S. Mendoza. He's based in Manila. He's going to talk about care for hypothyroid patients in the pandemic era. He will be joined by his moderator, who will join us from Bacolod City, Dr. Orabel Libutan. Bel, can you take over?
Yes, Doc. Good afternoon, everyone. So I am Dr. Orabel Libutan, your moderator for this session. So as mentioned, our next speaker will talk about the care for hypothyroid patients in the pandemic era. He is Dr. Eric Mendoza, a fellow of the Philippine College of Physicians and as well as a fellow of the Philippine Society of Endocrinology, Diabetes, and Metabolism. Dr. Mendoza completed his Doctor of Medicine, residency, and clinical fellowship at the University of Santo Tomas and finished his postgraduate clinical research fellowship in the National Institutes of Health, Bethesda, Maryland. He has a diploma in internal health from the University of the Philippines and completed Masters in Business Administration, Health Management in University of Makati. He is currently affiliated and a consultant in St. Luke's Medical Center, Quezon City, UST Hospital, and DOH Tondo Medical Center. He is also an esteemed faculty staff in UST Medicine and Surgery and UP Management and Development Studies. Ladies and gentlemen, a virtual welcome to Dr. Eric Mendoza.
Thank you, Dr. Orabel, for that kind introduction. So as Dr. Jeremy Robles mentioned, we have also to talk about hypothyroidism. And I prepared a recorded lecture for you, but along the way, you can type in your questions and we will try to answer them in the open forum.
Good afternoon, and thank you for staying with us. From the previous lecture of Dr. Nicodemus, we have learned a lot about the impact of COVID-19 on the pathogenesis, diagnosis, monitoring, and treatment of hyperthyroidism. On the other hand, or on the other end of the spectrum, is of course hypothyroidism. Let me present some of the evidences we have so far linking hypothyroidism and COVID-19 infection. The outline of my presentation will be as follows. We will discuss the current pathogenic link of hypothyroidism and COVID-19 infection on its molecular and cellular level. I will present a local case of COVID-19 related subacute thyroiditis managed in a tertiary COVID-19 facility. This patient presented with both thyrotoxic and, importantly, hypothyroid symptoms. After these, we will review the evidences and potential mechanisms on how SARS-CoV-2 can cause follicular cell destruction. We will discuss how COVID-19 infection can impose changes on the hypothalamic, pituitary, and thyroid axis. And of course, how it potentially affects the thyroid function test results we requested. This will be introduced by a typical patient admitted in the critical care unit wherein thyroid function test was requested. This will be followed by reviewing the outcomes of hypothyroid patients with COVID-19 infection. We will present a case of a patient with hypothyroidism seeking teleconsult. What are the information we need to gather that will affect monitoring and treatment in the setting of this pandemic? Finally, we will be presenting the statements and recommendations on the concerns regarding hypothyroidism, diagnosis, monitoring, and treatment from Key Thyroid Societies. What do we know about SARS-CoV-2, the agent of COVID-19 infection? A volume of literature has already proven that the virus has extrapulmonary complications with sequelae in the GI tract, cardiovascular system, coagulation pathway, immune system, and nervous system. The endocrine system, particularly the thyroid gland, is not spared with a systemic viremia and the overreactive immune response induced by the latter. It is postulated that hypothyroidism is a possible consequence of COVID-19 infection because of the following knowledge. First, the most common cause of primary hypothyroidism is Hashimoto's disease. One of the pathogenetic mechanisms of follicular destruction in this chronic lymphocytic form of thyroiditis is your bystander activation of autoreactive T cells caused by some viruses such as parvovirus, Epstein-Barr virus, and hepatitis C virus. So it is not unlikely that SARS-CoV-2 can mediate this follicular destruction both in chronic and subacute thyroiditis. In fact, it is already proven that ACE2 and proteins that mediate SARS-CoV-2 infection are expressed by the thyroid follicular cell. And lastly, severe and critical COVID-19 infection can potentially affect all levels of your hypothalamic, pituitary, and thyroid axis. In a recent article by The Economist, it is expected that more than 60% of Filipinos will be vaccinated only by Q4 of 2023. This is quite late in comparison to other neighboring ASEAN countries. This is assuming that there will be no resistance to immunization and there will be no more further delays in the procurement and rollout of the vaccine. Given the scenario of living with a pandemic in the next 2 years or so, it is important to know the burden of COVID-19 infection among special populations with comorbidities, including, of course, thyroid disorders. We all know that primary hypothyroidism and hypothyroidism as a result of treatment is common in the country. Hence, we must not only be adept in managing hypothyroid patients, but managing hypothyroid patients with potential or proven COVID-19 infection. It is not unknown to you that the SARS-CoV-2 uses the transmembrane ACE2 as its receptor. Successful entry requires another protein called your TMPRSS2 that primes the viral spike protein. In the figure presented, you can see the differential effects of hyperthyroidism and hypothyroidism in the angiotensin pathway. In particular, hypothyroidism decreases the expression of your ACE2 and its product, the heptapeptide angiotensin. One might think that because of hypothyroidism, there will be less chance of getting SARS-CoV-2 or COVID-19 infection. However, the effect of thyroid hormone on ACE2 expression is quite complex. As you can see in this next figure, in the presence of the transmembrane ACE2 coupled with your TMPRSS2, it facilitates SARS-CoV-2 entry into the cell. In the presence of another protein, ADAM17, which is a metalloprotease, ACE2 is cleaved from its transmembrane location, and this shedding can potentially keep virus at a distance from sensitive host tissues and preventing cellular entry. However, in the presence of low level of thyroid hormone, ACE2 as well as ADAM17 are potentially decreased. Whether this translates to increased likelihood of infection remains to be determined. Let me present a case managed by one of our residents in the DOH Tondo Medical Center. Last October 2020, she admitted a 44-year-old female presenting with sore throat, low-grade fever, and loss of appetite. She tested positive for SARS-CoV-2 RT-PCR. There was no pneumonia. She was managed as mild COVID-19 infection and was discharged after improvement of symptoms under extended home quarantine. 2 weeks later, she complained of palpitations, tremors, neck discomfort. She has tachycardia and there was mild tenderness on the anterior neck area. Thyroid function test result is consistent with thyrotoxicosis. When the resident consulted, our index of suspicion for thyroiditis was high, warranting further workup. We just gave the patient ibuprofen and beta blocker. Look at the ultrasound. It showed poorly defined hypoechoic regions on both right and left lobes. More definitively, the thyroid uptake is very low and the thyroid gland was non-visualized on the scan, confirming the etiology of your thyrotoxicosis. The patient was asked to follow up after 4 to 6 weeks. When she followed up, her thyroid function test is already on the hypothyroid phase of the subacute thyroiditis. We decided to give her low-dose levothyroxine to improve her symptoms. We requested anti-TPO antibody, and we will be monitoring her if she will progress to permanent hypothyroidism. To the best of our knowledge, we have not encountered a published literature that defined the hypothyroid phase of a COVID-19 related subacute thyroiditis. On this table, these are the selected case reports of COVID-19 related subacute thyroiditis. All are females. The interim between the thyrotoxic phase is as short as within the COVID-19 illness or up to 14 days as in our patient. Neck tenderness is quite common, but we may miss the diagnosis because our focus is usually on the upper respiratory symptom of the patient. Anti-TPO antibody may be a good prognosticator, but the thyroid uptake is still the most useful test to differentiate it from other forms of thyrotoxicosis. These are the proposed mechanisms by which SARS-CoV-2 causes thyroid dysfunction. First, inflammatory response, apoptosis, and local damage. In SARS-CoV-2 patients, inflammatory infiltrates have been noted in many tissues, including the thyroid gland. Second, there could be direct viral replication, but it is yet to be elucidated. In a paper by Rotondi, the presence of ACE2 in both the thyroid tissue isolates and primary cultures of thyroid cells is already proven, cementing the diagnosis or the evidence for COVID-19 induced thyroiditis. This favors more of a subacute thyroiditis form rather than your chronic lymphocytic thyroiditis form. Likewise, findings from the autopsy of the previous SARS-CoV-1 patients revealed that coronavirus can inflict damage on thyroid gland. On your left, you can appreciate the disruption of the follicular epithelium, likewise formation of cell clusters with no lumen, and congested capillaries. And on your right, you can appreciate the loss of follicles with increased fibrous tissue. More commonly, there are patients with pre-existing hypothyroidism that are admitted in the ward or ICU because of COVID-19 infection, particularly pneumonia. In the case presented, we have a 57-year-old female admitted in the COVID-19 ward. She has diabetes and primary hypothyroidism. Last month, She was seen in the clinic with A1C of 7.4 and normal TSH of 1.8 MIU per liter. She is on levothyroxine 100 microgram once a day. So it seems that she is adequately replaced. However, when she was admitted, there was a moderate COVID-19 pneumonia. She was started on remdesivir and dexamethasone 4 milligrams IV. Thyroid function tests showed slightly suppressed TSH and low T4. Our dilemma is that whether to increase levothyroxine because of the suppressed TSH or retain it in the light of a possible non-thyroidal illness or dexamethasone-induced suppression of TSH. Or some would think to increase it because of the low T3. Here are the potential issues of a patient with concurrent hypothyroidism and COVID-19 infection. The effect of the critical illness to the hypothalamic pituitary thyroid axis is very important. Also, the administration of high-dose steroids and vasopressors like dopamine can affect our thyroid function test results. Lastly, discordant thyroid function test results are more common for patients admitted in critical care units. Before we can offer the best decision concerning therapy, let us first review the data from cohort studies. To give light on the likely TFT results among COVID-19 patients, let us take a look at this study by Chen in a tertiary hospital in Hangzhou, China. He divided the cohort among patients with COVID-19, moderate to critical, healthy controls, and patients with non-COVID-19 pneumonia. Overall, patients with COVID-19 infection have lower TSH and total T3 versus healthy control and those with non-COVID-19 pneumonia patients. The total T4 was not significantly different from the other groups. On this next table, 50 COVID-19 patients were stratified into classes. Moderate COVID-19 infection if the patient has fever and respiratory tract symptoms. Severe COVID-19 infection if the patient has evidence of hypoxemia or 50% progression or more of lung lesion within the 48 hours. And of course, your critical COVID infection in which patients will require mechanical ventilatory support or if there is already presence of multiple organ dysfunction or shock. It is evident on the results that the more severe the COVID-19 infection, the lower the TSH value and the T3, total T3 levels. The degree of the decrease of TSH and total T3 was positively correlated with the severity. Finally, the investigator made a comparison between COVID-19 patients and non-COVID-19 patients with similar degree of disease severity. As you can see, for moderate cases, TSH, total T3, and total T4 were not different whether it is COVID-19 or non-COVID-19 infection. For the severe and critical cases, COVID-19 infection is associated with lower TSH than non-COVID-19 infection of the same severity. However, your total T3 and total T4 were statistically the same. Serum TSH levels, of course, is the one that is markedly depressed among more severe forms of COVID-19 infection. Still, as on the same study, it is important to note that none of the patients received thyroid hormone replacement therapy, and the levels of the TSH, total T3, and total T4 returned to normal after their recovery. COVID-19 affects the whole axis based on the evidence that's gathered. We already established cellular studies on the expression of ACE2 on thyroid follicles. Likewise, our own experience and case report back up this pathogenesis. The study presented showed a great possibility or probability that COVID-19 has this direct suppression of TSH from higher centers. Another data worth mentioning is that the study by Liu in 2005. Severe COVID-19 can cause low T3 syndrome or non-thyroidal illness. It also mediated by inflammatory cytokines, causes downregulation of your deiodinase 1. SARS-CoV-2 affects the nervous system as patients can present with anosmia and ageusia. It is also likely that higher centers such as the hypothalamus and pituitary can be affected. Finally, ICU drugs such as steroids and dopamine can suppress TSH and give discordant thyroid function test results. What are the potential outcomes among patients with hypothyroidism and COVID-19 infection? In a study by Jerwin involving more than 3,000 patients with COVID-19 infection, 6.8 or 251 subjects have pre-existing hypothyroidism. Unfortunately, only 22 patients have Hashimoto's disease. This is very few to make a subset analysis. The baseline characteristics were presented as follows. Hypothyroid patients are slightly older, predominantly females, and with comorbidities than the patients without hypothyroidism. Hypothyroidism was not associated with increased risk of hospitalization after adjusting for other factors such as age, race, BMI, smoking status, and number of comorbidities. Propensity scoring was also done. In this process, 241 hypothyroid patients were matched with patients without hypothyroidism after balancing the variables. The risk of hospitalization was not statistically significant. There was also no significant difference for the two other variables, which are the risk of mechanical ventilation and the risk of death. Using a probability curve, there was no significant difference in the survival between COVID-19 patients with hypothyroidism and COVID-19 patients without hypothyroidism. As a conclusion, there is no evidence that patients with poorly controlled thyroid disease are more likely to contact viral infections, especially the hypothyroid individuals. In this last case, this is a typical patient, a 46-year-old female who has post-surgical hypothyroidism last 2019. She was on levothyroxine 100 micrograms per day. Recently, she was skipping doses. She was lost to follow-up since the lockdown. And her thyroid function test results were as follows. Her TSH is slightly high, which is 6.7, and she has low FP4. So biochemically, she has signs of your hypothyroidism or inadequate replacement. The patient asked some questions. Am I at higher risk of developing COVID-19 infection, considering that my thyroid has been removed and my tests are not normal at this time? And do I need to stock or hoard a lot of levothyroxine? So let us review the statements and recommendations from Key Thyroid Societies. From the American Thyroid Association, are people with autoimmune thyroid disease, such as Hashimoto's thyroiditis or Graves' disease, more risk for acquiring COVID-19 infection or having a more serious COVID-19 infection? Having an autoimmune thyroid disease does not mean that a person is immunocompromised or will be unable to fight a viral infection. There is no indication that patients with autoimmune thyroid disease are at greater risk of getting COVID-19 or of being more severely affected should they acquire the COVID-19 infection. Also, are there any shortages of levothyroxine? Globally, there are no identified shortages of any types of these thyroid hormone replacement medications. In order to maintain social distancing and limit exposure to COVID-19 patients, patients should consider obtaining a 90-day supply of prescriptions. Also, is it safe to delay radioactive iodine treatment because of current COVID-19 pandemic? delay of 6 months or even longer do not appear to negatively affect the course of thyroid cancer patients. In general, treatment with radioiodine therapy is more urgent for patients who have papillary or follicular thyroid cancer that have distant metastasis to the lungs or other body parts, particularly if growth of the metastasis have been observed. There are also statements from the British Thyroid Association. They answer, does control of thyroid disease affect infection risk? Likewise, there is no evidence that those with poorly controlled thyroid disease are more likely to contract viral infections in general. However, this possibility cannot be discounted, so the Society strongly recommends that patients with thyroid disease continue taking their thyroid medication to reduce the risk. Our patients who have had radioiodine therapy or thyroid surgery in the past are at higher risk for COVID-19 infection. There is no evidence that patients who have recently received radioiodine or thyroid surgery for thyroid disease are at increased risk of general viral and therefore COVID-19 infection. And also, are there any considerations regarding supply of medication? During outbreak, stockpiling or hoarding of any medication should be avoided in order to ensure sufficient supply for all in the community. So what are the summary for the key recommendations in monitoring? There are actually no particular changes relating to the monitoring of hypothyroidism during COVID-19 crisis. But serum TSH and possibly including FT4 can be requested when patient is significantly unwell or with significant weight change, and of course, if the patient is pregnant or planning to get pregnant. For the treatment part, patients are advised to continue same form and dosage of thyroid hormone replacement therapy. The proper intake of levothyroxine should be emphasized 1 hour before breakfast and should not be given with medications that inhibit absorption, including, of course, calcium and iron. There is no indication that vitamin C and zinc negatively affects levothyroxine absorption. These two supplements are being taken by most patients during this time of pandemic. For the special considerations, patients with thyroid eye disease and on immunosuppressive medication, so they may have been treated for their Graves' thyroid disease by radioiodine or surgery, but because of the persistent Graves' ophthalmopathy, they are receiving immunosuppressive medication. We should take extra caution with them because of their immunosuppression can predispose them to infection, including COVID-19 infection. Pregnant women with hypo or even hyperthyroidism, they are associated with more severe COVID-19 disease. But I think this will be discussed by the next lecturer, Dr. Robles. In a nutshell, it is advised to have a doubling of the current dose on 2 days of the week. For example, the patient is taking 100 micrograms or daily or for 7 days. It is advised to increase the weekend dose during Saturday and Sundays to 200 micrograms per day once they learn that they are pregnant and have their thyroid function test done as soon as possible. Calcium and vitamin D must also be continued with the same dose if they have post-surgical hypoparathyroidism. We need to improve our endocrine service model during the pandemic with regards to telephone and video consultations. And also face-to-face appointments are encouraged for patients with enlarging goiter and patients with obstructive symptoms. Also, hopefully there will be satellite blood testing services for patients so that they will be of less risk in contracting COVID-19 infection in crowded places or the usual laboratory. So this is my final slide. The thyroid gland is a potential direct target of SARS-CoV-2 infection and destruction. COVID-19 infection affects all levels of hypothalamic pituitary thyroid axis. TSH and T3 levels are likely low, especially in severe COVID-19 infection. Hypothyroidism does not appear to increase COVID-19 morbidity and mortality. The management of hypothyroidism in the time of pandemic is mostly the same, but with special emphasis on equity on healthcare. Thank you very much for your kind attention.
Thank you so much, Dr. Eric Mendoza, for that very comprehensive and interesting lecture, as well as for presenting and sharing some cases and their respective management, some cases of thyroid disorders. So I would like to remind our attendees that you may post your questions in the Q&A panel. So since we don't have any questions yet coming from our Q&A panel, I would like to ask the first question. So you've mentioned that COVID-19 infection would actually induce subacute thyroiditis and also would actually affect our thyroid function. In your personal experience, Dr. Mendoza, do you usually or routinely check for thyroid function tests in patients infected with COVID-19?
Well, for the general population, there is really no indication to check for the thyroid function test, unless, of course, they are presenting with symptoms or signs, for example, of arrhythmia. So some doctors will try to rule out hyperthyroidism in these particular patients, or thyrotoxicosis for thyroiditis, for the subacute thyroiditis conditions. However, another differential for these manifestations could also be cardiomyositis from the COVID-19 infection. So unless the patient presents with sign and symptoms reflective of a possible hypo or hyperthyroid or thyrotoxic condition, then we request. And usually we want the complete panel, which is TSH, free T3 and free T4. But for patients who do not present with these particular symptoms, and if the index of suspicion is low or very low, I guess there's no point, no? It's not cost effective as well for most patients.
Okay, thank you for that, Doc. How about for the dose adjustment of levothyroxine? So would would you immediately like adjust levothyroxine, or would you just check a thyroid function test for patients with COVID-19 infection? Because as mentioned in your lecture, there is actually there is uh, thyroid function test would actually change if the patient has COVID-19.
Okay.
So
Ideally, it's not the best time to change the dose of the patient, especially if the patient is on a condition of critical illness, specifically for severe and critical COVID-19 infection, because of the many factors that I've enumerated, which are the critical illness, the medications that are routinely given to these patients, particularly steroid dexamethasone, if the thyroid function test was taken after giving the dose or the first dose of that medication. And also patients who have low blood pressure, and if they are on vasopressor, these can also affect the thyroid function test. So ideally, it's not the time to adjust the thyroid function test. However, we can do some adjustment in our decision-making pathway as well. Like in the data I presented, if your TSH is very low, then it seems that there's a factor called non-thyroidal illness operational in that particular patient if the FT3 is also low or the total T3 is low. But when you see a patient with high TSH and low FT4, even if the T3 or the FT3 is also low, then it seems that the patient needs to have a small adjustment in the dose of the levothyroxine. So I guess you look at the TSH. TSH is the best indicator for the thyroid status of the patient, because most of our patients have primary hypothyroidism or post-surgical or post-RAI hypothyroidism. So if your TSH is high, uh, the higher the level of the TSH, the higher your suspicion that the patient is inadequately replaced. But if the TSH is suppressed, especially slightly suppressed, the chances are that the operating condition at that time will be your non-thyroidal illness or thyroid syndrome, especially if it is backed up by a disproportionately low FT3. However, there's a caveat to that. Patients who are recovering from sickness, specifically for COVID-19, if they are in the recovery phase, it is not advised that you check for the TSH or the thyroid function panel, because the first response of the thyroid axis or the hypothalamic pituitary thyroid axis during recovery is increase in TSH. So if you follow them up, you can see that the TSH will increase until it pulls up the thyroid hormones FT3 and FT4 to normal range. And then you can only tell the true thyroid function level of the patient or the recovered level of these patients after about, depending on the severity of their illness, but usually about 6 to 12 weeks. So the range is quite, quite big.
Okay, so how about patients on levothyroxine? How would you advise when their maintenance brand is not available? If they would shift from another brand, when would you usually advise them to check for TSH? After 6 to 8 weeks?
Okay, I think the question is in reference to the recommendation that if the patients are doing well on a particular brand, it's really not advised to shift them, because as previous studies have shown, there are some differences in the bioavailability, in the pharmacokinetics or pharmacodynamics of different brands. So it is recommended to put them on the same brand. However, we are in a special setting right now in which there is a potential, but I don't think it's affecting most of the pharmacies around the country. But if there is a shortage, of course, you would shift the patient to another brand for that particular time. And ideally, uh, follow the usual monitoring for that particular patient. TSH would be the best indicator of adequate thyroid hormone replacement still. As I have mentioned, this is in the setting of a pandemic. Um, rather than not giving them thyroid medication or holding the medication, it's better if they will have the levothyroxine, even if it's from another brand. I mean, I think that's from public health standpoint and also medical economic standpoint. I mean, if they can get the same brand through other means, like order it somewhere and ship it to their particular locality, then that would be good. But for most, that would not be possible. So I think it's just right to continue levothyroxine even if it's of a different brand.
How about if the patient was shifted from another brand? So when would you suggest to check for the TSH? How many weeks after?
Well, there's really no recommendation for that particular question, but I would be comfortable checking for the TSH after, let's say, 6 to 8 weeks, if I really want to be sure that the patient is on the euthyroid or adequately replaced setting. However, the thing with hypothyroidism is you can afford to buy some time. I mean, there's really no danger if the patient will have a slightly high TSH, unlike, of course, in the other thyroid diseases in which it could give them some complications in a very short period of time, specifically thyroid toxicosis and hyperthyroidism. So I think 6 to 8 weeks is the optimal duration in which you would want to check their thyroid function test. But as I have mentioned, we are in a special time wherein resources are also limited. So you can give some leeway for the patient, especially if she is not manifesting overt signs of hypothyroidism. But it will be a different scenario if the patient is starting to gain weight, uh, complaining of joint pains, having some edema. So these clues will tell us that, oops, we need to check the thyroid function after that specified time period. Maybe we need to adjust, especially that we change the dose or the brand of the medication, or particularly levothyroxine.
Okay, so I think we actually we have another question. So in a post-thyroidectomy COVID confirmed patient who develops bradycardia and TSH level is on the high level, more than 3, is it advisable to increase LT4 dose, levothyroxine dose? So that would be our last question.
Okay.
Post-thyroidectomy.
So for this particular patient, that I assume that the TSH is around 3 to 4, right?
Yes.
Or even higher. So of course, it's better if you really know the patient, because you know the last laboratory test of the patient. If the patient has a TSH level of 1 to 2 and the patient was admitted this time with a TSH of 3, then you might want to increase the dose of the patient, especially the patient has bradycardia. There is no risk of cardiovascular wise, because it's just appropriate to give a dose adjustment, probably around 20 to 30% from the last dose of the levothyroxine will not harm and can even improve the patient. But of course, in this current pandemic, there are really differentials for the cardiovascular manifestations. As I have mentioned, myositis, cardiomyositis is also a thing to consider. Especially, there are some reports that post-viral infection, even not COVID, even in dengue, they could have this effect on the rhythm as well as reactivity of the myocardium. So I think for this particular patient, it can be beneficial to adjust levothyroxine dose. Of course, by just around 20 to 30%. That would be okay.
Okay, thank you so much, Dr. Mendoza, for that answer. So that was our last question. So this ends our second session, our second lecture. So I'll turn you over to Dr. Jeremy Robles.
Thank you, Belle, and thank you, Eric. We are on our last lecture for today. For the formal introduction of the next lecturer, who's actually me, I'm going to call in my moderator, Dr. Raquel Bruno. Raquel, if you're ready to take over. Go ahead, Raquel.
Yes, sir. So good afternoon, everyone. Seems like my filter, sir, is having a problem. So I'll just be removing my virtual background.
Okay, so while Raquel is fixing her background, we talk about the extremes of the spectrum here. Earlier, Dr. Nemi talked about hyperthyroidism and how to manage it. You now had Dr. Eric Mendoza taking care of the hypothyroidism. My last talk focuses primarily on a special population, and this special population is the pregnant patient that has thyroid problem. So there's interesting data on this, and I think that we will learn a lot as I go through the slides that I prepared this afternoon. Raquel, are you okay to start?
Yes, sir. Okay, so good afternoon, everyone. So for today's session, we will be talking about one of our special populations. So thyroid disease in pregnancy has always been a vulnerable state, even before this pandemic. So what might be its added implications and contingencies in the advent of COVID-19? So with this, I am honored to introduce to you our next speaker, who we've been seeing for the past few sessions. So he got his Doctor of Medicine degree from the Cebu Institute of Medicine, took his internal medicine residency in Cebu Valles General Hospital, his adult endocrinology fellowship in University of Santo Tomas Hospital in Manila, and a post-fellowship training in the National Institutes of Health in Maryland, USA. So currently, he is the treasurer of the Philippine Thyroid Association and an examiner of the Philippine Specialty Board of Endocrinology, Diabetes, and Metabolism. So he is also the training officer of Cebu Valles General Hospital, an associate professor of CIM, and a consultant in Sionglo Hospital, Cebu Valles General Hospital, and Perpetual Succor Hospital. So please help me welcome no other than the current president of the Philippine Society of Endocrinology, Diabetes, and Metabolism, and the scientific chair of this convention, Dr. Jeremy Jones Robles.
Thank you, Raquel, for that kind introduction. Let me share with you my slides for the last lecture for this afternoon. So the title of the talk is Managing Thyroid Disease in Pregnancy in the COVID-19 Pandemic. Indeed, it's quite difficult as a topic because you've had to go through a lot of the materials that do point to the relationship of COVID-19 and possibly through pregnancy. Unfortunately, there wasn't really much on the study of thyroid disease patients that go into pregnancy and having COVID-19 infection. But let's see what the information we have so far and what I have prepared. So this is the outline of my talk this afternoon. First, I'm going to present Philippine data on thyroid disease and pregnancy. Next, I'm going to review the thyroid physiology in pregnancy, and we will discuss important points for us to ponder on as we move on to the next topics that I will present. We will discuss available data, of course, on COVID-19 effect on pregnancy, and then we will summarize the recommendations on the management of thyroid disease in pregnancy during the COVID-19 pandemic. So it made my job easier because both previous speakers actually discussed some of the topics that I'm going to cover for this particular lecture. So I will end the lecture with the synthesis of information and share with you some of my personal insights as far as management of thyroid disease in pregnancy in the setting of COVID-19. So this is the data from the Philippines. This is PhilTides, the Philippine Thyroid Disease Study. This is the first one. We do hope to come up with the second one soon. And this is very important data that we've acquired. And we've shown here that the prevalence of thyroid dysfunction in the Philippines is actually about 8.53%. In contrast, or at least in relation to that, the prevalence of diabetes in the Philippines is about the same number as well. So both are really significant numbers for a small country like the Philippines, and especially because our numbers are really getting bigger. We now have a population of about 110 million. The distribution of thyroid function status is shown below. You will see that majority of the patients, about 91.47%, actually have normal thyroid function. And next to this, subclinical hyper and subclinical hypothyroidism are also shown here to be the next in line in terms of functional status of the thyroid of our patient. And really, true hyperthyroidism and true hypothyroidism appear to be a smaller number than what we actually expect. No? So this is very important data, and we'll start off here. But perhaps more significantly, our colleagues from UPPGH, particularly Dr. Patal, actually published a study. And this is a very important study because all the recommendations will tell you that your interpretation of the thyroid function tests of a pregnant should be in reference to a trimester-specific reference interval for thyroid function tests. And this one is specific for the Filipinos. Notice here that you have the values for TSH, FT4, and FT3 for the first trimester, second, and third trimester. And in this study of about 616 pregnant Filipino women, they checked the TPO antibodies. Majority of them, again, about 97%, turned out to be negative for TPO antibodies. But what did we learn from this information? We know that the TSH rises with age of gestation. The FT4 was found to be lower on the second trimester, but starts to recover as it goes into the third trimester. And then the FT3 decreases also in the third trimester. So try to keep this in mind as we look at this graph that has been classically been shown to a lot of our lectures with regard to the physiology of thyroid hormones. And this is very important because you can see familiar names here. Dr. Cooper, who had studied a lot of thyroid disorders and thyroid diseases. And I think this graphic representations will help us understand better what levels of hormones are actually prominent at certain times of the trimester of pregnancy. So let's look at this closely. In the first trimester, we do expect that the TSH actually goes down. And the reason for this is that of the HCG homology, the alpha subunit, which we notice the HCG goes up during the first trimester as well. So admittedly, the TSH will go down on your first trimester. And in fact, if you get referrals asking for what to do, you will see in this graph that the dip in the TSH actually even extends beyond the first trimester. It goes into the second trimester and slowly recovers back to normal levels up to the third trimester. So what about T4 or FT4 for that matter? FT4 slightly elevates in the first trimester and slowly dips on the second and eventually dips at its lowest point on the third trimester. Total T4 plateaus in the second trimester. And of course, your beta HCG goes down. So these are important points that you need to remember. So both of these information is very important for you to understand the physiology and eventual pathology of thyroid dysfunction in pregnant women. So trimestic specific reference intervals will help you identify whether or not this patient really has a problem with the thyroid hormone levels at that particular trimester in pregnancy. And obviously, it is a complex relationship if you look at all the hormones involved into pregnancy. So indeed, it's quite interesting to note that all of these interplay needs to be taken into consideration when we deal with patients that are pregnant, especially with thyroid disease. Of course, we have to note here, and very important, we have to emphasize that iodine levels should be sufficient. And therefore, we recommend our patients really to have adequate iodine intake. So let's review again 6 key hormones in pregnancy that change in the different trimesters that we have. You have beta HCG that elevates in the first trimester. It plateaus in the second trimester and eventually goes down on the third trimester. Both your progesterone and your estrogen actually goes up on the second to the third trimester. Prolactin goes up together with your oxytocin, which is more prominent at the stage that these patients or these pregnant patients actually give birth. Relaxin initially spikes, not as high as your beta HCG, but eventually it will also dip later on in the pregnancy. Again, that's just showing the interplay of hormones that are present in a pregnant patient. So this is another very important slide. And this was taken from a paper entitled Thyroid Function and Thyroid Disorders During Pregnancy, a Review and Care Pathway. It's taken from the Archives of Gynecologic and Obstetrics. So here, you're able to see the relationship between fetal FT4 and maternal FT4 in relation to central nervous system and thyroid function development. Notice that in the first trimester, this is very important, the fetus is not able to produce its own FT4. And therefore, it is really the mother that is essentially giving the baby or the fetus the FT4 that it needs to develop the central nervous system. And that's why it's very important that you're able to pick up patients early on if there are any derangements in the thyroid function of these patients early on, as early as even the first trimester or second trimester. And you do this by doing appropriate history taking and looking at the familial history and medical history of the family if there's any history of miscarriage or any strong familiar history of thyroid problem in the family. Now, I talked about iodine. Iodine is the source for your thyroid hormones, and therefore we should not forget it. And in fact, the intake of iodine ideally should be targeted at around 250 micrograms per day for the pregnant and lactating mother. This is just one of the more important points that you need to stress, especially in pregnant women. So in the Philippines, the situation is quite different from everywhere in the world. We still have this problem of iodine deficiency. In fact, they have identified areas in the Philippines, shown here in the darker color, to be iodine deficient or having some sort of moderate iodine deficiency. And this is in Central Philippines, in the area of Aklan and Panay, in Negros, and then you have Southern Philippines in Zamboanga, areas in Autonomous Muslim Mindanao, as well as Davao and the southernmost tip of the Philippines. So again, you're talking about a syndrome and a spectrum of diseases that when we talk about thyroid disease in pregnancy. So on one end, you have hyperthyroidism, overt hyperthyroidism, those with really a hyperthyroid state pre-existing or prior to pregnancy or even during pregnancy. You have a subclinical hyperthyroidism and a beta HCG related hyperthyroidism, which eventually will resolve. On the other hand, you also have hypothyroidism. So it can come as overt hypothyroidism, a subclinical hypothyroidism, or isolated hypothyroxanemia. Of course, extreme hormone derangements, both of hyper and hypo, are associated with poorer outcomes, both from the mother side and the fetal side. And therefore, you need to be more aggressive in treating these medical problems. Subclinical thyroid disease, however, will warrant further workup and may need medical treatment if the risks are present, or whether or not these patients in your risk assessment will need these medications. Of course, isolated hypothyroxanemia remains controversial. There are studies that suggest that it may put these patients at risk for a difficult pregnancy, but the other studies also negate this. So it remains to be a questionable judgment, and therefore the current recommendation is really to assess individually these patients whether or not there is a need for treatment for isolated hypothyroxanemia. So prior to COVID, and the two other speakers have talked about this, the treatment for hyperthyroidism was really simple and outright. Workup for suspected hypothyroid pregnant patients, those having with TSH of more than 4, consisted of TSH, FT4, PPO antibodies, or TG antibodies, and the ultrasound of the thyroid. For those suspected of hyperthyroidism with a TSH of less than 0.1, TSH again, FT4 TRAV, if you strongly suspect Graves' disease and thyroid ultrasound as well. You follow these laboratories every 4 to 6 weeks. You follow the TRAB every trimester for the Graves' disease patient. For the treatment of hypothyroidism, levothyroxine about 1.6 milligram per kilo for overt hypothyroidism and 1 milligram per kilo for subclinical hypothyroidism. Then you assess for history of miscarriage, TPO antibody presence, and of course, you consider treatment if really these patients are high risk. For hyperthyroidism, PTU is the preferred drug in the first trimester. For the second and the third trimester, methimazole is now your drug of choice. Of course, you target the lowest possible dose to achieve mild maternal hyperthyroidism. So let's review the literature and the latest information we have for COVID-19 and pregnancy. So you've seen this slide earlier, as shown by Dr. Mendoza. So we know that the ACE2 receptor is the main receptor where the COVID virus actually attaches. This is very important because the ACE2 receptor is quite different from your ACE1 receptor. Now, if you're giving patients ACE inhibitors, primarily it is the ACE1 that is inhibited. Now, theoretically, this may cause some upregulation in your ACE2 receptors. However, clinically, this was not shown at all. And therefore, the recommendations from our cardiologist friends was that just to continue ACE and ARB treatment. So the other receptor that you need to be aware of is a Dpp-4 receptor. The Dpp-4 receptor is also another alternative attachment where your SARS-CoV coronavirus can actually attach and gain entry to your cell. Now, if you're giving Dpp-4 inhibitors, again, theoretically, this can actually help you protect your patients. No? But if you're obese, you're overweight, or you are diabetic, the risk for COVID infections dramatically increases. In fact, that's included in the top 3 morbidities that you have for patients that do get the COVID infection. And the reason for this is that note that diabetes is an inflammatory disorder. And as an inflammatory disorder, you do have elevated levels of TNF alpha, interleukin 6, interleukin 1 beta. And of course, the key here would be the interleukin 6. So these inflammatory markers are actually the ones causing the problem. And therefore, that puts our patients at risk for infection with COVID, SARS-CoV virus. You've also seen this slide earlier last Monday with Dr. Matawaran, showing the various metabolic aspects of COVID-19 infection. It does affect patients, particularly the obese patients. It can worsen the outcome of diabetic patients. It can also affect by lowering your vitamin D with hypocalcemia. And of course, higher susceptibility in outcomes in men, as well as some derangements with your adrenal gland, in particular, adrenal insufficiency, and probably patients with Cushing syndrome can be pushed to stress as well. But I want you to focus on the 2 other points that's being shown here. This one is on the left upper quadrant, which is the pituitary gland, as well as the thyroid gland. So most of the studies that has been shown here in previous lectures ever since the day 1 have shown that it's mainly sick thyroid syndrome, a temporary state. This temporary state actually recovers after some time. And therefore, you just really have to follow them. You don't have to treat these patients. But what about the pituitary gland? Let's talk about pituitary dysfunction. So remember that in your pituitary gland, you also have receptors for your ACE2 receptors in the pituitary gland. And because of this, they can affect hormonal control in the pituitary level that can be translated into derangements on the end organ hormone production as well. So dysnatremias, pituitary dysfunction, as well as transient derangements may be evident among patients with COVID infection. Let's move forward with some of the studies that correlate COVID-19 as well as pregnancy outcomes. For this first study, we looked into non-pregnant patients. The total number is about 334 COVID patients versus 122 non-COVID patients. This study was done by the group from the National Institutes of Health and published in the Journal of Clinical Endocrinology and Metabolism just recently. Okay, so the findings of the study showed that some mild reductions in TSH and FT4 were actually seen in patients, and this is consistent with non-thyroidal illness or sick thyroid syndrome. The survivors of COVID-19 actually had a return to normal of their thyroid function test, particularly on the 2nd and even the 3rd month post-recovery of the COVID infection. But let's look at the table closely below. If you notice, all the patients, majority still had euthyroid state. Those with COVID negative patients had about 86.9% being euthyroid. In contrast, about the same also with COVID-19 positive patients. Now, it didn't really matter much if you survive, non-survival, non-ICU or ICU admitted, all of them manifested with very high percentages suggesting euthyroidism among the state of these patients. But next to euthyroidism, you also notice that subclinical hyper and subclinical hypothyroidism was prominent in some of the patients. This was the next most significant finding among these patients. In fact, hyperthyroidism, overt hyperthyroidism, was not really seen among a lot of the patients, but hypothyroidism did appear in a couple of patients that had COVID-19, and these are similar data that you will see later among pregnant women. So there are explanations to this. This study tended to support that COVID-related thyroiditis and thyrotoxicosis was not really commonly seen, but rather more of non-thyroidal illness or sickle thyroid syndrome could be seen among patients with COVID-19. There are possible explanations why TSH is suppressed, and really, this is just a reversible situation. But again, this goes back to the explanation of the pathology and pathophysiology of your COVID-19 infection. So because of elevated pro-inflammatory cytokines, they have a negative correlation with TSH. The culprit here is interleukin-6, which apparently elevates also in the presence of a COVID infection. Endogenous cortisol secretion may suppress your TSH because, admittedly, these patients are really stressed with the infection. And of course, possible direct cytopathic effects of the virus in the pituitary ACE2 receptors. So there's a direct effect with ACE2 receptors in your brain, in particular in your pituitary gland. So overt thyroid dysfunction was not seen among patients that had COVID-19 in this subset of patients. And therefore, the conclusion was that long-term follow-up was really needed to see if these patients will actually have other derangement further on, or they will recover fully. So let's move on to pregnancy outcomes among women with and without severe acute respiratory syndrome coronavirus 2. So you're looking at pregnant women, 252 with COVID, 3,000 non-COVID. SARS-CoV infection in pregnancy was not associated with adverse pregnancy outcome. Early neonatal SARS-CoV infection did occur in 3% of the patient. And whether or not these were vertical transmissions, it's not really clear, but it was a relatively lower percentage than what we were expecting. What is important here was that there was no placental pathology differences by illness severity, and therefore they didn't really see any significant pathology in the placenta of the mother that was giving birth. Most of the patients were asymptomatic at the time of their infection, but there were some that progressed to critical COVID infection. And let's see, here I highlighted the reason for admission. Most of the time, it was still because of obstetric indication and not because of the pneumonia. You will notice, as I mentioned, majority of them had asymptomatic COVID-19 infection, but 2 actually had progressed into critical COVID infection during the latter part of their pregnancy and when they were about to give birth. There were also some patients that had already existing severe COVID infection that worsened to critical, 2 of them, and 1 remained in the severe. But overall, in terms of outcome, they were a bit favorable. So as I said, it was quite difficult to look for data on hyperthyroidism among patients with COVID. But the initial data coming in from Wuhan, and this is studied by Zheng et al. And published in the International Journal of Gynecology and Obstetrics, did show some information that appeared to be interesting for us looking into this topic. Of course, there were correlations as far as comorbidities. Most of the comorbidities were related to either cardiac problems or some sort of problems with your blood sugar. But in particular, some of the studies have already shown that hypothyroidism was found among these patients. They didn't really specify which type of hypothyroidism, but for this subset of patients, 16 in fact, 2 of them was diagnosed with hypothyroidism. And these are women with childbearing age, and they were the ones that actually gave birth, despite the fact that they had COVID-19 already. None of these patients did suffer from a severe form of COVID infection, but note that delivery was 12 of these patients delivered via cesarean section and 4 with vaginal delivery. Other studies have shown, and this is a retrospective cohort study from China with 28 pregnant and 54 non-pregnant. They've shown in their profile that at least one of the patients from each of the subgroups did have hypothyroidism, and that the age range was comparable for both of these groups. And again, we will see that cesarean delivery was more prominent among these patients over vaginal delivery. The good part here is that there's no fetal death, neonatal death, or neonatal asphyxia observed with this subset of patients. So what about effects of COVID-19 infection during pregnancy and neonatal prognosis? This study is a systematic review of 775 pregnant women and 598 infants. More than half of them had cesarean sections. 82% of the infants tested were tested with SARS-CoV, but only 2% tested positive. So there's no evidence for vertical transmission based on what this data is showing us. But the recommendations are the same, that you need to follow these patients to make sure of the long-term effects of COVID. So this is probably one of the more interesting studies that I came across. This is a comparison of a pre-COVID pandemic set of pregnant women in their first trimester, no thyroid disease, no thyroid treatment. You're comparing group 1 between January 20 to March 31, 2019 versus the during pandemic group, January 30 to March 31, 2020. So you're looking at two groups and two different timelines here. The second group during the COVID pandemic had higher FT3. This is statistically significant, lower FT4, isolated hypothyroxemia, and lower thyroglobulin antibody positivity. And that's shown here in the table below. So how do they explain this? Remember that these are a subset of patients that are on their first trimester or early pregnancy. And this is data coming in from frontliners of endocrinology. And again, this is coming from China. So isolated hypothyroxemia, as I previously said, were associated with higher risk for preterm and probably neurocognitive dysplasia. Again, it's debatable. Some say that it is just a transient situation and that it will resolve by itself. But often we follow these patients closely in the hope that it will resolve by itself. Or if needed, if these patients are high risk, we may have to give treatment to these patients. Thyroid autoantibodies, TPO antibody and thyroglobulin antibodies have been associated with suboptimal development of offspring, particularly for neurologic deficits that are present among these patients, unfortunate patients. But we never talked about anxiety, and this study looked into the level of anxiety of patients. Apparently, the thinking of the authors was that the anxiety actually amplifies the TSH and enhances the FT4 to FT3 conversion. Of course, they have not yet given enough data on this, but the hypothesis seems to coincide with the data that they have presented earlier. Similar data and significant data have shown that those patients with higher BMI are associated with higher FT3 and lower FT4, isolated hypothyroxemia, and thyroglobulin antibody possibility. The other finding was that higher maternal education with more comprehensive knowledge, higher income, and access to good medical resources and better preventive measures did have a positive effect on the patients. Less anxiety and depression and less significant difference in hormone levels. So apparently, there is a psychiatric and psychological component to this particular dilemma of patients being faced with COVID-19 pandemic. So those are interesting studies. As I said, it's very minimal in terms of what data we have now, and I think we need to continue to read about this so that we will understand better what the situation is with thyroid disease in pregnancy during COVID. So here are general precautions that I will echo from the previous speakers that have talked about our spectrum of diseases. All patients should maintain updated contact information for healthcare providers, your doctors. Telemedicine will now play a significant role. Ensure that you have enough medications, but don't hoard or stockpile. Emergency precautions should be discussed with your physicians. Elective endocrine visits should be deferred. No? So in fact, the follow-up of these patients will have to be discussed if really they need to go into the hospital or the clinic for follow-up, or if they can do this online with teleconsult, or probably delay the follow-up as long as the hormone levels are within normal limits. They should be updated with the recommended vaccinations, and they should be informed of various resources available online for them to understand their disease, and of course, for them to be able to protect themselves. So here are general recommendations again, coming in from the European Journal of Endocrinology. Social distancing, of course, to minimize the risk for infection. Treatment of hypothyroid patients should continue and the dose should be adjusted, as previously mentioned by Dr. Mendoza. However, these adjustments may warrant that you get in touch with your doctor so that you can be appropriately guided in terms of how you will make your adjustments for the treatment. Thyroid function testing should also be adjusted, and take note of trimester-specific references, as I mentioned. PTU-B4 in the first trimester, and then methimazole on the second and third trimester are your drugs of choice for hyperthyroid patients. And of course, STRAB for follow-up testing. Since the recommendation was to do it every trimester, you might have to pull that back into twice during the pregnancy or as needed based on the recommendations of the doctor. So here are some contingencies of endocrine services. Telephone and video consultations will now be taking center stage for a lot of the patients that don't really need to come into the clinic and to come into the hospital, just to protect them from getting infected from COVID, especially during community transmission. Remote monitoring services are very important, particularly for patients with long-term treatment of antithyroid medications and hormonal replacements. So face-to-face appointments will still be needed, but you have to discuss whether or not these are actually needed at the time of your visit, or you can do with teleconsultation or telemedicine. Of course, there are subsets of patients that will need to come in, worsening thyroid eye disease, enlarging a goiter or enlarging thyroid gland, and of course, those that will not or not responding to standard treatment. They've also suggested satellite blood testing services, and this would mean laboratories or point of care or laboratory care outside of the main hospitals, just to mitigate the risk for infection. So here are some more information, and this is coming from a position statement from Indian Thyroid Society. For hypothyroid patients, there is no evidence that pregnant women with hypothyroidism and hyperthyroidism are increased risk for COVID-19, and that those taking medications have not been proven to be at risk as well. Pregnancy, because of the changes in the immune system, may have an immunocompromised state if you're pregnant, and therefore viral infections such as COVID-19 may be a considerable risk for this subset of patients. All patients taking levothyroxine should continue to take these medications. What about hyperthyroid patients? There's no evidence that these patients are at risk for COVID-19. No evidence that patients taking antithyroid medications are increased risk for COVID-19 as well. Okay, and the higher risk for severe disease are those patients that are already morbid to begin with. So assessments may be necessary for these patients. So what about recommendations from JAFES? So Journal of ASEAN Federation of Endocrine Societies also looked into autoimmune thyroid disease that does not necessarily increase the risk for COVID-19 mortality and morbidity, and that both medications for hypo and hyper should be continued to be taken, and it doesn't necessarily mean that you're taking these medications, you are at risk. The recommendation is still to continue all of these medications. Of course, as previously mentioned, antithyroid drugs may need to be differentiated with a granulocytosis caused by sepsis or another infection. So medication should be stretched, prescribed 2 to 3 months over a monthly follow-up that we used to do, so that you can decrease the frequency of clinic visits. So once you've reached the target levels, you can follow these patients and probably space out the follow-up dates for a lot of these patients. These are data and these are specific information that are actually echoed from the recommendations and position statements from the British Thyroid Foundation, American Thyroid Association, and American Association of Clinical Endocrinologists. So the recommendation still stands, no? So if you think about it, in terms of managing COVID-19 in the COVID-19 pandemic, the pregnant patient with thyroid disease, our treatment really is about the same as what we used to, despite the fact that the spectrum of diseases will have problems and the spectrum of diseases will need treatment. We will follow these patients, and we will need to treat them appropriately with safety of our patients as well as the medical staff as well. So I'm going back to this particular slide that I showed earlier. There are no recommendations to change the therapeutic management to date or status quo. Workup will be the same for hyper and hypothyroid patients. The treatment is about the same. The only difference is the timing for the visit and the mitigation measures for our patients not to be exposed or to be put at risk for COVID-19 infection. Because as shown earlier in several of the studies that I presented, it can pose a significant morbidity to a pregnant patient, especially during the latter part of the pregnancy. So here are my personal insights, and this is my last slide. COVID-19 is a significant threat to the global population, but more so with specific populations. The preliminary data shows a variety of manifestations that reflect mild derangements, transient derangements that may eventually normalize with time. There are no long-term studies that are available, and therefore we need to follow our patients and share our data. The literature is dynamic. There's still so much that we need to know about COVID-19 and its effect on the body. And we know all need to be updated. Not only the patients, also the doctors, especially the healthcare providers. Pregnant with pre-existing thyroid disease should continue taking prescribed medications as directed and keep in touch with their physicians. And telemedicine is the key. And that's why we have a lecture on telemedicine on Friday, which I hope that you will join. Lastly, the general principles of management still apply. There's no change. It's status quo. We continue to treat our patient based on our assessments. And if we need to do closer assessment, then that is what we need to do for our patients. Extreme caution is needed to mitigate the risk of COVID-19 infection because of the many things that can happen if you have COVID-19 infection. I think that's the last slide. And thank you so much for listening and staying with us up to this third lecture for today.
Yes, so thank you very much, Sir Jeremy, for a very relevant, timely, and encompassing lecture. So far, we have learned about the physiologic changes in pregnancy, thyroid-wise, the added effect of COVID-19 on the pituitary thyroid axis, and we were given a review of the latest fresh literature out there on the implications of COVID-19 in pregnancy and on its outcomes. So as Dr. Robles has said, management is still the same, status quo, and it's quite reassuring that based on the studies, we don't have direct adverse pregnancy outcomes so far for patients who acquired COVID infection. So it seems like our attendees are still enthusiastic, sir. We still have a couple of questions here in our chat box. First question, sir, do you treat subclinical hyperthyroidism in pregnant patients with arrhythmias?
Okay, so that's a very interesting question. I think that the short answer is probably you need to do more workup for these patients on why these patients have some arrhythmia. And then you're going to have to call in your friendly cardiologist to help you figure out whether or not the arrhythmias are caused by thyroid disease. And if it is caused by thyroid disease, a full workup, again, with the patient will be needed on why these patients are manifesting with subclinical hyperthyroidism. So that being said, subclinical hyperthyroidism has been associated with some reports that it puts the patients at risk for difficulty in pregnancy, as well as potential risk for derangements or probably some problem with your delivery, as well as the outcome of your pregnancy. So that being said, full workup will be warranted. And once you have the full workup, you will need to treat as needed.
Okay, thank you, sir. The next question, sir, I think it's not related to pregnancy, but is it safe to delay thyroid surgery because of the COVID-19 pandemic?
Yes, I think that question will be answered on Friday, when we will have the panel discussion with thyroid malignancy, as well as the interactive discussion with topics related to that. But just to quickly answer the question, if you're pregnant in case that this doctor is asking about the possibility of thyroid malignancy in pregnancy, before the recommendation was to do surgery if you can on the second trimester, but there were also recommendations, in fact, to move the surgery after delivery, since most of the thyroid malignancies actually are not fast growing. And therefore, you can consider delaying the surgery after the postpartum state or after delivery. Raquel, I think you're on mute.
Okay, so thank you very much, sir. So I think that's quite clear, sir. In the interest of time, sir, since we will have our open forum, so you may also raise your questions for our two previous speakers. So thank you again, Dr. Jeremy Robles. So before we end today's session, we'll have an open forum for those speakers if you have additional questions. This can be your time to raise them. This is Raquel Bruno from Iligan City in Northern Mindanao, wishing everyone a pleasant evening.
Thank you, Raquel. I'll be taking over as the moderator for our special session for today. So I'm asking Dr. Eric Mendoza and Dr. Nemi Nicodemus to rejoin me as we try to answer some of the questions coming in from MedSynapse. Let's see. Of course, some of these questions that they're sending in are from our delegates coming in from the European states as well as the Middle East. No? Okay, so there's a question here asking is, if a patient goes into thyroid storm during the second trimester of pregnancy with a BP of 220 to 120, what are you going to do? It seems to be a very complicated question for a typical patient, no? So I would imagine that it would have been a very stormy course if you think about it, or maybe this patient didn't really do any follow-up prenatally if she reached the second trimester with such a scenario. So any thoughts on this, Nemi and Eric? I'll start off with Nemi, who lectured on hyperthyroidism.
Definitely,
so this patient
it's
is thyroid
complicated
storm.
issue. Yes, during pregnancy. And we know that, of course, a lot of our patients, in fact, during pregnancy, tend to have their hyperthyroidism controlled, especially nearing the term, because of the effect of pregnancy on controlling the hyperthyroidism itself. So it is quite, when you do encounter a pregnant patient who goes into thyroid storm, that means you really have an uncontrolled patient who perhaps even prior to pregnancy has not really had a good control of the hyperthyroidism. So what do you do in such cases? Of course, you have to give the usual regimen. You have to give your patients your loading doses of your PTU. And of course, if also possible, to give these patients your saturated solution of potassium iodide. And because the blood pressure is very high, of course, the patient is, because of the pregnancy, has a high risk of developing eclampsia. And so in such cases, aside from the usual beta blockers that we may give for the hyperthyroid state, it is also important that you coordinate and collaborate with your OBGYN to control the eclampsia of this patient, or the possible preeclampsia of this patient.
Thank you, Nems. Eric, you want to add something?
Usually, pregnant patients, even though they are hyperthyroid and they undergo this thyroid storm, they will not have this very high blood pressure. It's really important to rule out, like what Dr. Nicodemus mentioned, rule out other pregnancy-induced hypertension like preeclampsia. And I think OBs will give magnesium sulfate, well, aside from us managing the thyroid storm, until, of course, the 24-hour urine protein creatinine is determined. But for our part, we will treat as another case of thyroid storm. So give all the necessary medication, especially the antithyroid, and steroid perhaps will be a good adjuvant as well for this patient. Well, since this is pregnant, I'm thinking that dexamethasone will be a better choice than the usual hydrocortisone that we give to our non-pregnant patients who have thyroid storm.
Thank you, Eric. I think we need to emphasize here that the fact that this patient is hyperthyroid can actually contribute to the hypertension of the patient. No? So if you think about it, maybe not entirely hypertension because of hyperthyroidism, but I'm pretty sure that somewhere along the way there has to be some sort of synergistic negative effect with the hyperthyroidism, and therefore I think you need to be more aggressive in treating both of these problems. No? So the fact that this baby remained viable in the second trimester with thyroid storm, with hypertensive crisis, means that we need to do everything to actually save this baby. No? So in the next question, and I wanted to get Eric's reactions on this. For post-total thyroidectomy patients who are pregnant, what is the recommended dose for replacement? Your thoughts, Eric?
Okay,
and I'll share mine after you.
As Dr. Robles mentioned, for non-pregnant individuals, the usual median dose for patients who have their thyroid removed, whole thyroid removed, is 1.6 microgram per kilogram body weight per day. In the pregnant physiology, there are literature that tells us, or evidences, that there is an increase of about 25 to 30% requirement. But of course, this has some variations per pregnant patients. That's why we monitor the thyroid function test of pregnant individuals more frequent than the non-pregnant hypothyroid patient or patients who underwent total thyroidectomy. So a good decision pathway is to increase the dose even if you don't have the thyroid function test yet. Once you learn that the pregnant individual is or the hypothyroid individual is pregnant, so increase the dose by 30%. That's roughly equivalent to addition of 2 more doses from the usual 7-day dose of the patient. And then after that, we base it on the thyroid function test results of the patient.
Nems, what if you overcorrect? So what if you did give based on how Eric calculated it, and then you overcorrected it and the patient goes to you? How do you go about adjusting the medication?
Well, it is important that we use our thyroid function test as a guide. And as mentioned by Eric, really, when you do start them with the initial dose of 1.6 microgram per kilogram body weight per day, as mentioned, it is just the initial dose. So either that dose is sufficient, insufficient, or even overly replacing the patient. And so it is important that we do monitor our repeat TSH in particular to know and to make the TSH be within the reference range for the non-pregnant person. But of course, for pregnancy, there is another, we are aiming for less than 2.5. And what is important is that we can adjust the dose. As you mentioned, Jeremy, no, if you have overly replaced your patient, how do you do it? Well, if we are to follow a simple algorithm, you can reduce the daily dose of your patient by as much as 12.5 to 25 micrograms per day. So you can reduce it by that amount, depending on how high, on how suppressed rather the TSH is. And then you can send this patient with this revised dose and then come back after another 6 to 8 weeks with the repeat of your TSH. One other strategy that I have also used in my practice, and it's also recommended by some experts, is that you may also remove the dose or reduce the dose on a particular day of the week. So sometimes instead of giving the dose on a daily basis, you can remove the dose on a single day. And so instead of 7 days a week, they will be just taking the dose for 6 days a week. So again, this is because of the half-life of your levothyroxine, which is around 7 days. And again, using TSH as your goal.
Thank you, Nems and Eric. I think all of the speakers will agree that the key here will be the laboratory results of the patient as a guide on how we should make our adjustments in terms of the dose that we're actually giving to the patient. So a couple of scenarios being asked here, a bit complicated, but I'll try to simplify it for our speakers. Post-thyroidectomy, total thyroidectomy, Apparently, this is a thyroid CA patient. She actually wants to lose weight, but is not able to do so. She's asking if regular physical exercise will still have a role to play because she is already menopausal. She actually is on thyroid medication, about 100. Whether or not she should increase these medications with the goal of losing weight in mind. I think you need to factor in these are two problems, no? So, and then this patient apparently had good follow-up, but because of COVID, wasn't able to do the testing, including the anti-TG, which is also very important for post-thyroidectomy, thyroid malignancy. And Dr. Schoberg Ko and Wesley Lauderes will talk about that on Friday. But your thoughts on this, Eric, what do you think? Post-thyroidectomy, papillary CA, wanting to lose weight. Apparently, the levothyroxine 100 gives these patients a within range TSH. However, in terms of weight, no improvement. Two problems or related problem? Your thoughts?
Well, for me, if the TSH is within the optimal level, whether you're targeting a suppressed uh, level because of the high-risk papillary thyroid carcinoma or the poor response to treatment, or just enough or in the median range because of the excellent response, if it's in that particular range, I think we have to explore other factors affecting the weight gain of the patient. Of course, the eating habits, the exercise of the patient, and other factors affecting obesity. Although there are some studies that mention that a combined T4 and T3 would have a better effect when it comes to the metabolic profile of patients who needs thyroid hormone replacement. But unfortunately, aside from it is not, those are not large studies, and number two, it's not available locally. So we just have to be contented with the preparation that is locally available, which is levothyroxine or LP4. So it's also dangerous for this patient to be given a supraphysiologic level of levothyroxine, considering that she is already, I think, in her 50s. So the risk of osteoporosis and possibly tachyarrhythmia are all there. So I think better to explore other means now of losing weight. That's for me.
Nems, you want to add something?
Yes, I think it's important for us to educate our patients that levothyroxine is not really a weight loss drug. That is very important. And here, the reason why we are giving our patients levothyroxine is because this is a thyroid cancer patient, and levothyroxine has a role in suppressing the recurrence or even metastasis for the thyroid cancer. And if the TSH, as mentioned by Eric, is already in the level that is desired for this patient, then there should be no need to increase the levothyroxine dose just for the purpose of weight loss. In fact, at that time, at that stage, it might be important really to look into the other factors as mentioned by Eric for the patient to lose weight, like the diet. Of course, physical activity is always recommended even at ages that are advanced, except that, of course, the exercise regimen will have to be modified based on the age of the patient. But then, yes, physical activity may be prescribed in order to lose weight. And of course, very important, the diet must also be monitored and the patient must be advised properly with regards to the diet.
Thank you, Demi and Eric. I'll try to answer this question. No? So the question is directed to my topic. As a healthcare worker working in a COVID-19 environment, specifically in public health, I am 30 years old, diagnosed with subacute thyroiditis last month. Me and my husband is planning to have a baby. Is this in the time of the pandemic, is it advisable, doc, to get pregnant? So very interesting scenario. Of course, we wish you all the best, no, with your plans. However, I think it's very important again because we're talking about the thyroid. You need to be able to do a follow-up testing of how your levels of the hormones actually are. No, so the current hormonal levels will actually determine whether or not you are in the best state to get into your pregnancy. And you will really have to follow up with your doctor, especially if you are having subacute thyroiditis. And as you know, subacute thyroiditis will have several phases. You can have a hyperthyroid state that goes into hypothyroid state. So depending on what level or at what timing you are in, you may need further help to interpret what your current status is. And the key here again would be you getting your blood works done and talking to a physician to discuss really what's the plan going to be. And they're going to be working hand in hand with the OB/GYN with regard to how to approach your plans for pregnancy. So best of luck. And of course, we hope all the best for you, for any healthcare provider. We really want to extend the help, and that's the reason why PTA is here for you also. So we are broadcasting live. If you want to join us, there's one more session this coming Friday. So last question for everyone. I'm a diagnosed papillary thyroid CA. I'm immunocompromised. Can I still do my job as clinical instructor and supervise my students to complete their cases in the hospital? I'll start off with Nemi. Can you comment on this?
Okay. Of course, we know that a lot of educational institutions now have shifted from a face-to-face session to the virtual classroom. And in the case of the patient being diagnosed with thyroid cancer, I would still, of course, advise the patient to continue with the work as an instructor. But I think I would advise more on utilizing the virtual platform for the instruction, so that at least at this time we can still manage the exposure to possible COVID.
Thanks, Dems. Eric?
For this
I think
particular
Eric is
patient,
having some problems
it
here.
depends on the response of the patient to the previous therapy, such as the radioactive compromised status. However, of course, I hope this is not the scenario that if it's an advanced stage carcinoma, then maybe
So I think Eric got cut off. I'll follow with what he was trying to say. So for this particular patient, if you're a clinical instructor, so I'm thinking that you're probably a nurse, but definitely someone working in the front lines. So there's an unusually higher risk for all of us working in the front line, and that's why we need to be really careful in handling a lot of the cases, especially with the deluge of cases that we're getting into. Ironically, when the vaccine is already arriving and we're having this very upsurge of cases, so you need to be careful. I think that with proper care, social distancing, and being conscious of the risk that you are facing, you can still protect yourself and function significantly to help others and make others do their job. So especially that you are a clinical instructor, you play a very important role in taking the lead for a lot of our healthcare providers. So I'll put back Eric in. Eric, you were saying, sorry, you got cut off. You're on mute, Eric.
sorry for the connection problem. I don't know where I was cut off. Other patient, the pregnant patient, I think it's important also to measure your antibody because it's a prognosticator for pregnancy and fertility. As papillary thyroid has excellent response from radioactive. I don't think that would he or she, I hope, not papillary thyroid cancer. So it would really matter.
So thank you, Eric. Yeah, I think we lost Eric. But anyway, thank you, Eric, for answering that question. Okay, so that's day 2. And I think all of you will agree we've learned so much. We as speakers learned so much. Of course, you as our audience definitely got the best information that you could probably get. I'm very happy with our speakers today. I think all of us did a good job in sending the message that, thyroid disease is something that's very serious. And in the presence of COVID, that makes things a little bit complicated. Nems, a few words from you before we close?
Yes, indeed. The second day of our virtual convention, it has been very informative, very interesting, and our topics, I think, are very timely and very relevant. That's why we have a lot of questions. And thank you again to Dr. Jeremy Robles, our scientific committee chair, for bringing such very good topics together for our day 2. And again, just to interest everyone, on Friday, we will have our third day, and we do have very interesting topics as well. And of course, very exciting speakers. So we do hope that you will still join us on Friday. And for our colleagues who want to be members of the Philippine Thyroid Association, we are still accepting membership, and we do hope that on Friday we can pledge you in as our members. Thank you.
Thank you, Nems. And of course, we have to end. So this is the last part of our day 2 for our PTA convention. I'm glad to be able to host again the events for today. We will do the same on Friday. We do hope that you will join us. The rest of the topics that were not covered in the first 2 sessions will actually be covered on that particular day. We're going to talk about thyroid malignancy and what contingencies actually they were able to come up with during the time of COVID. Of course, 2 very significant and very timely topics. The one on robotic surgery, as well as telemedicine as the last lecture for the day and for the whole conference. So once again, I want to thank everyone for joining us at the PTA Annual Convention. I'm your host for today. I'm Dr. Jeremy Robles, signing off for day 2 of PTA.